Good morning, good afternoon, good evening, wherever you are. Welcome to another intensive care hotline and intensive care at home. Your questions answered live. And I also want to welcome you if you're attending this call live or if you're watching the replay. Thanks for your support anyway. We're getting more and more followers, more and more subscribers. We're helping more and more clients that have families in intensive care, either with our consulting and advocacy at intensive care hotline, and also with our intensive care at home nursing service, where we help families and patients to get out of ICU, even though they might be on a ventilator, might have a tracheostomy, and improve their quality of life at home. So welcome to another live stream where I answer your questions in real time. Type your questions into the chat pad or dial in live on the show and we can get them answered, and I can get them answered. Now, before we go into today's questions answered, just a little bit about myself in case you wonder what makes me qualified to talk about today's topic, what makes me qualified to answer questions from families in intensive care on a live stream, or what makes me qualified to answer questions about intensive care at home on a live stream, publishing it all over YouTube, Facebook, LinkedIn, Twitter, and so forth. So my background is I'm an intensive care nurse. I have worked in intensive care / critical care for over 20 years in 3 different countries. Out of those 20 years, I have worked as a nurse unit manager in intensive care for over 5 years. So I have seen all the works in ICU. I've covered a range of specialties in intensive care: general, neuro, trauma, cardiac, pediatrics, and obviously intensive care at home as well. I was part of pioneering intensive care at home in Germany to begin with over 25 years ago, and then I was pioneering it here in Australia, and we launched intensive care at home here in Australia from the ground, and we have now helped dozens of families in intensive care to leave intensive care and improve their quality of life at home with our intensive care at home nursing. Currently, we are predominantly operating in all major capital cities in Australia, where we provide intensive care at home nursing. So, without further ado, let's get into today's questions. Again, you can type them into the chat pad here, or you can dial in live on the show. If you are watching the recording, you can also dial those numbers when you're not outside of the show, because those are our numbers for intensive care at home and intensive care hotline. You can call us there. So let's dive into today's questions. So first question that I have prepared now while waiting for live questions is: my dad is in intensive care and has been there now for 2 months. He is assisted for his breathing, heart and kidneys, and has perforated bowels. I believe the doctors want us to turn his machines off, but I feel like he will pull through. He's 77 and they have given him propofol. He doesn't seem responsive to us. Is this because of the medicine, as he was responding to us before he had another setback? And then our reader goes on and says, hang on. No, and that is what the reader says. Now, okay. Perforated bowels in ICU is a big challenge, because what that means is there's a very high chance of your dad ending up with abdominal sepsis, and that is a big challenge for any patient in intensive care. because that could, abdominal sepsis could develop into multi-organ failure, and, and that could require him to need dialysis. It could require him to need prolonged ventilation. It could require for him to have a tracheostomy. I mean, he's in ICU for 2 months already, which means he must have a tracheostomy already. But, let's just say your dad was only in ICU for a few days with a similar picture, he would most likely need a tracheostomy. But anyway, so you're already saying that he's assisted for his heart and kidneys and for the breathing. So, one could argue he is already in multi-organ failure, but that should not stop you from, pushing along. What it means is basically his breathing is supported with a tracheostomy and a breathing machine. His kidneys are supported probably with a dialysis machine or intermittently with diuretics, which is medication that can be given IV, such as furosemide, Lasix, or Bumex. With perforated bowels, again, I would be very surprised if he didn't have an abdominal septic picture, and if he has been to surgery multiple times for abdominal washouts, to clear the tummy area. You believe the doctors want us to turn his machines. He's 77 and they've given him propofol and he doesn't seem responsive to us. Well, here is the thing, Manish is your name. Here is the thing, Manish. So if he has a tracheostomy, he shouldn't really need propofol. A tracheostomy is so much easier to tolerate than a breathing tube. So, for example, if your dad had a breathing tube, he most likely would need some propofol to be able to tolerate the breathing tube. But if your dad's been in ICU for 2 months, he must have a tracheostomy, especially if he's ventilated. So one of the reasons someone should have a tracheostomy is simply to eliminate the need for sedation and an induced coma. Okay, because going from a breathing tube, which is very uncomfortable, to a tracheostomy, which is way more comfortable, should be the aim of the game, should be the goal. Therefore, propofol should not be needed. Now, what can happen in a situation like that? You're not describing it in much detail, but I'm, counting 2 and 2 together. And I have seen those situations many times, that he might not be comfortable with the ventilator, that he might potentially be fighting against the ventilator and therefore needs to be sedated. What's the way out of the dilemma? Well, he might not be able to breathe with ventilator because he might be in pain. Abdominal sepsis can be very painful, or bowel perforation can be very painful, and maybe pain needs to be better controlled so that he is able to tolerate the ventilation a bit more, right? And then he may not need the propofol. So start looking at how is his pain controlled with the perforated bowels, right? Does he, for example, have an open abdominal wound? So what I've seen over the years is sometimes when someone has perforated bowels and abdominal sepsis, they have an open wound, an open abdominal wound with a vac dressing, and that can be very painful, right? So it also could mean that he may not be able to sit up, and if he's not able to sit up, that could diminish his chances of weaning off the ventilator, right? He probably won't need the propofol if he can wean off the ventilator, because then he can have time off the ventilator, he can breathe spontaneously, and then eventually the ideal scenario is that the tracheostomy can be removed and the ventilator can be removed, but it doesn't sound to me like he is quite there yet. So what else is important? So you are talking about that they are supporting his heart. So what that means most likely is they're probably supporting his heart with vasopressors or inotropes. So commonly used medications that are inotropes or vasopressors are noradrenaline, norepinephrine, epinephrine, adrenaline, levophet, phenylephrine, dobutamine, dopamine, sometimes milrinone as well. Other less commonly used inotropes are isoprenaline, levosimendan, and some of them are more for heart failure as well, if the contractility of the heart is down. So again, it comes back to Manish, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's really, what I can help you with here, getting to the bottom of things, because when I read through your email, the ICU team has probably not even told you half of the story of what's going on, right? You didn't give any details, so I must assume they haven't even told you half of the story. And this comes down to, families in intensive care don't know what they don't know. You need to know what questions to ask. Now, I've given you a hint what questions to ask already. You should be asking for ventilation settings, right? Why does he need the propofol? Is it because he can't tolerate the ventilator? Is it because they put him on the wrong ventilator settings, right? What are his arterial blood gases like, right? Those are all questions that need to be asked in a situation like this. Next, with the bowel perforation and the abdominal sepsis, most likely, they would give him antibiotics. They must have isolated the bug, and therefore, once they've isolated the bug and they know what bacteria they're dealing with, then they can target the bacteria with the right antibiotics. Okay, so find out what antibiotics he's getting, and is it the right antibiotic, right? Ask them, what is the actual bacteria they're dealing with, and is the sepsis or the infection in the abdominal space the only infection they're dealing with? What else is happening? Is there infection in the lungs? The longer someone is ventilated, the higher the chances are that a patient in ICU ends up with a ventilator-associated pneumonia. Okay, so with a ventilator-associated pneumonia, that could be another spanner in the works, and it could, again, diminish his chances of getting off the ventilator. Both needs to happen, Manish. Both needs to happen. He needs to be able to wean off the ventilator. The sepsis needs to be cleared. I hope they've repaired the bowel perforation. Other questions that could come up in a situation like that is, does he have a colostomy bag or an ileostomy bag, right? Next, you're saying, I believe the doctors want us to turn off the machine, but I feel like he will pull through. Well, you should follow that gut feeling. You know your dad best. Even if he's 77, you know your dad best, whether he's a fighter, whether, he would want to live. You should trust that gut feeling. Very important that you trust your gut feeling in a situation like that. Then he was obviously responding to you beforehand, and I'm not surprised that he's no longer responding, because he's now back on the propofol. So what you're describing with me, Manish, the following, I believe, needs to happen. Find out what antibiotics he's on. Find out, what are they doing to treat the infection? Does he need to go back to the operating room? Does he need to go back for surgery? Then other things that need to happen: get rid of the propofol. Manage pain really well. Pain really needs to be managed well in those situations. You might need a pain review from a pain specialist to get pain under control. And then find out what ventilator settings he's on. Find out what ventilator settings he's on. Send me a picture of the ventilator. Find out what his vital signs are. Find out his blood results. Find out the medications he's on. And talk to them. What do they think is next? Right? So that would be my advice here, Manish. And hopefully all goes well, because the longer he stays on the propofol, the longer they're fiddling around with the abdominal sepsis, the less likely it is he will get off the ventilator and the tracheostomy. Now, God forbid, if he can't come off the ventilator and the tracheostomy, reach out to us here at Intensive Care at Home and see whether we can take your dad home, right? So there are options for you going forward. So I hope that helps. Then, next question. Oh yeah, that is also from Manish. Follow-on question. I should also mention, while his lungs started to improve, he aspirated while in ICU twice and developed sepsis as well as part of the aspiration. And he is currently bleeding from the mouth, followed by episodes of tachycardia. Yeah. So unfortunately, again, like I mentioned before, the longer someone is ventilated in ICU, the higher chances for things to go wrong, i.e. aspiration pneumonia, even ventilator-associated pneumonia. And he aspirated twice. That is really very unfortunate, and developed sepsis. And he's bleeding from the mouth. So if he's bleeding from the mouth, find out. There could be two main reasons why he's bleeding from the mouth. There could be simply a mechanical injury when they're doing mouth care, but that could also be because he is check his coagulation, right? What's his APTT like? What's his INR like? Are the platelets low? Those are questions that need to be asked in a situation like that when someone is bleeding. What's his hemoglobin like? Red blood cells in the blood. Does he need a blood transfusion or two? Right? Is he on anticoagulation such as Clexane, also known as enoxaparin? Is he on heparin? Those are all questions that are important to ask in a situation like that. Okay, let's move along to another question from our readers. Alexa asks, my mum is in ICU with multi-organ failure with underlying severe acute pancreatitis. She's ventilated, requiring FiO2 support 50%, blood pressure support, and dialysis. What are our next steps? What questions should we ask regarding further treatment? Today, she has had a pseudocyst drained via ultrasound endoscopy and fluid drained from a pulmonary edema. 700 mils was drained. She's 67 years of age. Okay. Alexa, you're talking about, multi-organ failure with underlying severe acute pancreatitis. Not surprised that with acute pancreatitis, she is having challenges with multi-organ failure, similar to our previous question with an abdominal sepsis. Whilst a pancreatitis is not the same, it's not too far off from abdominal sepsis either, because its pancreas is in the abdominal space. So again, similar to our previous question from Manish, so when someone is having pancreatitis, multi-organ failure is what can follow from that, i.e. kidneys are failing, lungs are failing, the heart is failing, which is exactly what is happening here. Maybe the liver is failing too, we don't know. You haven't specified, but certainly we can confidently say that lung, heart, and kidneys are failing while she's on dialysis. So again, what are they doing with the pancreatitis? I would hope she's nil by mouth. She's not having anything to eat. I would hope they started her on TPN. If you haven't heard of TPN, TPN stands for total parenteral nutrition. Most patients with pancreatitis need to be nil by mouth to not stimulate the pancreas any further, because the pancreas is usually swollen during a pancreatitis. So therefore, patients need to stay needle by mouth, and they get started on TPN, total parenteral nutrition, also known as IV or intravenous nutrition. With intravenous nutrition, you're bypassing the gut, right? So nutrition goes straight into the bloodstream. So that would be my first question for you, Alexa. Have they started her on TPN? So the pancreas is no longer getting stimulated. And what are they doing there? And if she's needle by mouth without TPN, that would be a big concern, because it means she's not getting any nutrition. You haven't shared how long your mum has been in ICU with this, but she needs to get some form of nutrition. What questions should you be asking regarding further treatment? Okay, so she's ventilated, requiring O2 support 50%, blood pressure support, and dialysis. She had a pseudocyst drained via ultrasound, endoscopy, and fluids drained from a pulmonary edema. 700 mils was drained. She's 67 years of age. So questions are, starting from the top, starting from head to toe. What's her neurological condition? You haven't mentioned whether your mum is awake or not. Is she awake? If she's not awake, are they sedating her? Are they giving her pain meds? Pancreatitis can be very painful. I would imagine she's on strong opiates, either fentanyl or morphine, or another opiate along the same lines. Is her brain intact? Do they have reason to believe that her brain is not intact? Again, you haven't shared really, is she awake? Is she alert? Is she not asleep? Is she not awake? You haven't really shared anything there. So on 50% of oxygen, what are her arterial blood gases? How likely is it she can get off the ventilator? Ask for the exact ventilator settings. Is she breathing on her own, at least for parts of a cycle? So that's the ventilation side of things. How often does she need suction? You haven't mentioned how, or whether she's got a breathing tube or a tracheostomy. Again, if she has a breathing tube, after about 10 to 14 days in ICU, a tracheostomy should be done, assuming your mum can't come off the ventilator, right? Next. So she's got a pseudocyst drained by ultrasound. She had fluid drained from a pulmonary edema. 700 mils was drained. She's 67 years of age. Wow. If they've drained 700 mils, that's a lot. That is a lot. 700 mils. Wow. From a pulmonary edema. Wow. Is it a pulmonary edema, or is it a pleural effusion? Right? If you could clarify that, that would be really helpful. So, if she's in kidney failure, why can't they remove the fluids via the dialysis machine or via the hemofilter? Why can't they do that? You got to ask that question. Why is it that they are draining with a chest drain and not remove the fluids via the dialysis machine? Those are some very relevant questions. Now, other questions are, how often does she need suctioning? What are her arterial blood gases? Are they considering a tracheostomy? Again, that all depends on how long she's been in ICU for and how long she's been ventilated for. Next, is she on vasopressors or inotropes, right, to support the blood pressure, right? So you mentioned that she is on dialysis. How much are they removing? Are they aiming for a negative fluid balance, meaning is more urine going out than fluids going in? Very important during the time when someone is in kidney failure. So then, what's her temperature like? What are her blood results? Is her white cell count up? Is her lactate up? Is her hemoglobin up or down? Right? Really, really important questions. What are her electrolytes like? For example, what's her potassium like? What's her magnesium like? Very important electrolytes to be monitored in ICU at pretty much all times, so she's not going into an irregular heart rhythm. Next, is she having feed? Is she absorbing feed? We talked about that. You know, how are they managing the pancreatitis? Next, 67 years old. You know, again, ask the question around the TPN if she doesn't have TPN already. Next, is she opening bowels? Does she have any reflux from the nasogastric tube or maybe from the PEG tube, depending on what tube she has for nutrition, right? Is she absorbing feeds? Is she opening bowels and so forth? Is she having pressure sores? Right? So those are some of the questions you want to ask. Now, next question, and this is a good one, not that others aren't, but you know, this is one that I probably like to talk over and over again because it comes up so often, and I think it is important that people understand it. The next question was sent by Leanne, and Leanne says, why are ICU departments so negative all the time? Recovery takes time, yet they seem to think after 3 days, if someone doesn't reply to command, it's a negative thing. Okay, let me get to that. I'll just very quickly need to change my position here. I'll be right back. Apologies for the delay. So, let me talk about this. So why are ICUs negative all the time? I answer it in a broadly first, and then I'll come to Leanne's specific question. Recovery takes time, yet they seem to think that after 3 days, if someone doesn't reply to command, it's a negative thing. So why are ICU departments negative all the time? So simple answer is they're negative by default. Okay, why is that? For a number of reasons, including but not limited to managing beds, managing staff. ICU beds are in high demand. What's the ICU team's worst case scenario? The ICU team's worst case scenario is, you know, looking after a patient indefinitely with an uncertain outcome. And many patients in ICU, quite frankly, tick that box. They are ICU patients with an uncertain outcome, and you could look after them indefinitely. Okay, so that's one reason, not the only reason. Next reason is to stay in control of the narrative. What do I mean by that? So imagine ICU teams came to you and they said, hey, we're going to look after your dad for the next 2 weeks, or after your mom, and then you know, we'll do X, Y, and Z, and then your mom will go out of ICU and she will be fine. Now imagine ICUs would make that promise or that guarantee, and then it doesn't happen. You could sue them. You could sue them. And they certainly don't want you to sue them. So you have to take everything with a grain of salt. And you know, you have to read between the lines that they're trying to manage their downside. So what I mean by that is, you know, if they are not promising you anything, it means your expectations stay low. If they're staying negative, your expectations stay low, which means it's easy for them to tell you if your dad, your mom is going to die, not going to improve. It's easy for them to tell you, well, I told you so, right? Whereas again, look at the other side. If they came to you and they said, hey, you know, give us a couple of weeks here, we do X, Y, and Z, and then your mom or dad will leave intensive care and they will be cured. And then it's not going to happen. That, you know, could get them into all sorts of trouble. And they certainly don't want that. Now, Leanne is furthermore saying, recovery takes time, yet they seem to think after 3 days, if someone doesn't wake up and doesn't reply to command, it's a negative thing. Absolutely, Leah. Absolutely. 3 days is nothing. 3 weeks is nothing in ICU. Things take time. But again, it's all about staying in control of the narrative. It's all about, wanting to empty that bed when it's convenient for them. And if they tell you, well, 3 days in ICU and your mom, your dad, your brother, your sister, whoever it is not waking up, it's easy for them to say, well, it's all negative, it's all doom and gloom, they will never wake up. Well, we know it can take weeks, months, sometimes years for someone to wake up. Now, also depends, what you haven't shared, Leanne, is if your loved one has a brain injury, has no brain injury, not waking up after 3 days after an induced coma is not a long time. Not waking up after a brain injury after 3 days is not a long time. Some people might argue that not waking up after 3 weeks after an induced coma or a brain injury is not a long time. And I would fall into that category where I say it's not a long time. People need time. With intensive care at home in particular, we have clients that have been in ICU for months, sometimes for years, and they want to live, and they are at home now, and they have quality of life. So why you got to ask the question, why do ICUs want to prematurely withdraw treatment after 3 days? What's the rush in killing someone? What's the hurry? And I'm getting tired of ICUs saying, oh, well, we are acting in the quote unquote best interest of a patient. No, you're not. The best interest of a patient is to live. That is the best interest of a patient. And yet ICUs claim they are the only ones knowing what's quote unquote in the best interest of a patient. It's up to the patient, it's up to you and your family what's in the best interest, because you know your loved one. So don't get bogged down by the negativity. Just stay objective and advocate for what you want for your loved one. That's all it is, really. Don't overcomplicate, and that's a lot of questions actually we get from our clients. They say, how should I say to the ICU team what I want to say? I say to them, just say it. Just say it. The best way to sell a horse is put up a sign, horse for sale. If you want to continue treatment for your loved one when the ICU team is telling you, well, we shouldn't continue treatment, well, the best way to tell them is, I want to continue treatment. Don't overcomplicate. We can give you all the insights, of course, with, all the clinical side. We can give you the rationale clinically, but before you do anything, just tell them what you want. Do not, do not buy into their negativity. Do not buy into the doom and gloom. 90% of ICU patients survive. Roughly 90% of ICU patients survive. Why should your mum or your dad be 1 out of 10? It's much more likely that your mum belongs to the 9 out of 10. Right? So you gotta be very clear on what you want, and you cannot be shy. And you cannot be shy of asking for what you want. You can never be shy of asking for what you want. I hope that helps. I also want to quickly talk. I have other questions here as well. And if in the meantime, if you want to type your question into the chat pad, feel free to do so while I'm looking for other questions that have been emailed to us. But in the meantime, type your questions into the chat pad or dial in live on the show. And I can answer them live on the show. You don't have to mention your name. You can stay anonymous if that's what you prefer. Now, while I'm looking for another question that we've been emailed this week, just quickly want to mention about, again, the quote unquote best interest discussion. That ICU teams always say, well, we are acting quote unquote in the best interest of your loved one. Well, in some cases that is true. In many cases, especially when it comes to end of life or perceived end of life, it's not true. So it's as simple as that. Now, another question that we had this week is, I'm looking for information to help me understand what will happen after open heart surgery. Great question. Great question. Now that COVID is slowly settling down, hospitals are back to more open heart surgery, because that was another thing that went out of the window during COVID, because there simply were no ICU beds for open heart surgery, or not enough ICU beds. So what should happen after open heart surgery is a number of things. Number one should be, it depends on whether someone goes into ICU for open heart surgery for elective open heart surgery or for non-elective open heart surgery. So the difference is, elective open heart surgery is planned, can be planned weeks, months in advance. Non-elective open heart surgery basically means emergency open heart surgery. Okay, so the difference is that elective cardiac surgery or open heart surgery, there's often a lag time. Someone has maybe angina pectoris, maybe they have shortness of breath, they've got blocked arteries, but there's still time to get prepared for the surgery, maybe medically, maybe in cath lab with a coronary artery dilatation, maybe with a stent, but nevertheless they need to have open heart surgery in the next few weeks, next few months. That's one way. If that's the case, then cardiac surgery should be quote unquote straightforward. Patients go into ICU after cardiac surgery, they get warmed up because they're going to be very cold after theater. They stay in an induced coma, lightly induced coma, for a few hours with propofol, maybe with a little bit of midazolam/Versed, with some fentanyl or morphine to manage pain. If the approach is quote unquote wake and wean, so what that means is wake the patient up, wean them off the ventilator, make sure that they're hemodynamically stable, make sure they're weaned off inotropes, vasopressors, vasodilators, which they can also often have after cardiac surgery, such as GTN or SNP, to keep the coronary arteries patent after open heart surgery. Because if they're not staying patent, there may be another heart attack happening and surgery was in vain. Okay, so that is when cardiac surgery, I'm still on the topic when cardiac surgery is straightforward, wake and wean, get them off inotropes, get them off vasopressors, get them off vasodilators, make sure they're not bleeding, they have chest drains in their drain, make sure they're not bleeding. And if that is all the case, they should go back to a cardiac ward day one after surgery. That's it. They often follow a pathway where boxes need to be ticked. Now, there's other things as well. Sometimes patients come back after open heart surgery with a pacemaker, temporary pacemaker. They can often go back with being temporary paced to the ward. Make sure there are no cardiac arrhythmias, such as atrial fibrillation, such as junctional rhythm, such as any heart blocks and so forth, right? So monitoring electrolytes such as potassium and magnesium, but also others, are very important after cardiac surgery. Okay. Now, if their hemoglobin has dropped, for example, because of severe bleeding during surgery, they might need a unit of blood or two, or if they're bleeding, they might need platelets, FFPs, fresh frozen plasma. But the approach should be to get them back to a ward as quickly as possible, short stay in ICU. Once they're extubated, once they're off the breathing tube, breathing exercises are going to be really important, because when patients were on ECMO or on the bypass machine during surgery, their lungs are collapsed, right? So the surgeons can operate on the heart. That's why the lungs are collapsed. Now, with that said, it takes time to reinflate the lungs. Now, there's a risk for lung collapse. There's a risk for atelectasis, right? Atelectasis means collapse of the lungs. So in order to prevent that, you got to do good breathing exercises. Ask the patient to take deep breaths, ask the patient to sit up, ask the patient to cough, put a towel on their chest so it's not hurting when they're coughing after open heart surgery, because they've cracked the chest open, right? For lack of a better term. So mobilize them early. Okay, mobilize them very early on, so they can expand the lungs. Imagine you're lying in bed all day with pain, because the chest drains are painful, the wound from the surgery is painful, but try and sit up as quickly as you can, or the patient needs to sit up as quickly as they can, ideally day one. That also prevents hopefully deep vein thrombosis, and then get them out to the ward, get them on their path to recovery again as quickly as possible. Now, that's the best case scenario. What's a not so good scenario? A not so good scenario is when someone goes into ICU after non-elective open heart surgery, after emergency cardiac surgery. What does that look like? Well, it can look like a patient goes into ICU after a heart attack, after cardiac arrest, after a severe blockage. They go to the catheter lab where the cardiologists look at the coronary arteries. Are they blocked? Well, if they're blocked and they can't unblock them with a stent or with a dilatation, then patients often go into ICU with after open heart surgery, and maybe they've had a massive heart attack, right? And then maybe patients have difficulties weaning off the ventilator, okay? Maybe patients preoperatively were on medications such as clopidogrel or Plavix or aspirin or warfarin even, to keep the blood thin because they might have had a cardiac stent or whatever. Maybe they were bleeding post-operatively because they had to go for cardiac surgery in a rush, and now they're bleeding post-operatively because the blood thinners weren't stopped in time. Okay, so then you have complications with bleeding. Then patient might need to go back to surgery after cardiac surgery to stop the bleeding, right? If a patient is bleeding after cardiac surgery, there's the risk of cardiac tamponade. What that means is if the heart is bleeding after surgery and the blood can't be drained, then blood accumulates in the cavity around the heart, expands, and can basically stop the heart from beating because the heart no longer has space to beat, no longer has space to contract, right? That could lead to cardiac arrest. So monitoring after cardiac surgery is really, really important, right? And you have special devices such as, you can check your central venous pressure, you can check your cardiac output, cardiac index, SVR, systemic vascular resistance. You can check your wedge pressure. Often after cardiac surgery, patients come back with the Swan-Ganz catheter. So, I'm not going into too much detail about what the doctors and the nurses need to know to manage all of that. But what you need to know as a family member or maybe as a patient yourself is that the risk is there for a tamponade, but there are ways to look out for the signs. Other complications that can happen after cardiac surgery is that sometimes patients come back on an intra-aortic balloon pump, right? Where they've done cardiac surgery, but the balloon pump is needed to support the heart. Okay, the balloon pump ensures that more oxygen is going to the coronary arteries after cardiac surgery, and then once the heart is more stable, it can be reduced, it can be weaned off, it can be taken out. Okay, that should also happen simultaneously with increasing or decreasing inotropes. That is what's often needed to support the heart, such as dobutamine, dopamine, milrinone, sometimes levosimendan after heart attack or after cardiomyopathy or during cardiomyopathy. Medications as such can be used as well. Next, when cardiac surgery is not straightforward, again, very important to monitor electrolytes, and unlike my example before, when cardiac surgery is straightforward, patients do not go to the ward on day one. They often stay on the ventilator for longer. They might stay on the ventilator for 2 or for 3 days. The goal is to get them off as quickly as possible, because the longer they stay on the ventilator, there's risk for complications, such as ventilator-associated pneumonia. There's risk for thrombosis to develop. There's risk for stroke. There's risks for a PE, pulmonary embolus, right? So the sooner you can get someone off a ventilator, get them to breathe normally, get them back to normality, get them off all the support for the heart, inotropes, vasopressors, the better it is. But that's not always the case. Sometimes, there are multiple complications that can occur, including, again, what I mentioned before, atrial fibrillation, AFib, junctional rhythm. heart block. Maybe they need to be paced for a period of time, go on a temporary pacemaker, right? So those are all complications that can happen. Worst case scenario is, again, someone can't come off the ventilator. They even end up with a tracheostomy down the line. You don't want that to happen. But I've certainly seen it happen over the years. It really depends on how sick a patient is when they first come into ICU for open heart surgery. And it also depends on their pre-medical history. Okay. And what I just mentioned before, intra-aortic balloon pump, depending on why patients go into ICU for open heart surgery. Sometimes they even have an intra-aortic balloon pump before surgery to give the heart a bit of a rest, to prep the heart, to make it a bit stronger. That can happen too. Then what I've also seen on rare occasions is that patients come back after open heart surgery with ECMO. ECMO stands for intracorporeal membrane oxygenation. It basically takes over the function of the heart or the lungs for a period of time. Maybe things really went horribly wrong during surgery, God forbid, and they can't come off, the bypass machine can't come off ECMO. Again, that should be temporarily, ideally. Okay, I hope that gives you a snapshot. I have done other videos about, what should happen after cardiac surgery in a bit more detail, broken it down into even more detail in those other videos. But for now, that gives you an idea what can happen after cardiac surgery. Okay, now, so that's what I wanted to cover today. I do another YouTube live again next week around the same time, Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 6:30 p.m. Eastern Standard Time in the US, 3:30 p.m. Pacific time, 5:30 Central Time, 4:30 Mountain Time. UK, it's Sunday morning, half an hour past midnight. Okay. Any other questions? You can also type them, next to what if you watch this video on replay, you can also type them in, and I will get to them, and I will get to them in another YouTube live. Or if you have any other questions, just give us a call on one of the numbers. If you have a loved one in intensive care, or if you have a loved one that you want to take home with intensive care at home, just contact us on one of the numbers on the top of our websites, or simply send us an email to support@intensivecarehotline.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related there. Also, if you need a medical record review, please contact us as well. We review medical records for patients in ICU in real time, and we review medical records after intensive care, but it's obviously much better, much more beneficial for you and your family if we review them in real time while you have your loved one in intensive care, so we can interpret clinical data for you in real time, and we can help you asking all the right questions. But also what I'm doing, I'm talking to doctors directly. If that's what you want me to do, I can participate in family meetings over the phone or in person as part of my consulting and advocacy. Now, if you like the video, give it a thumbs up, share it with your friends and families. Of course, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the notification bell when there's a new video, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from Intensive Care Hotline and Intensive Care at Home, and I will talk to you again next week in a live stream, but also during the week. Watch out for my quick tip videos. Take care for now.